In this next section, we will look at the treatment of hypertension. Blood pressure is the product of cardiac output and total peripheral resistance. Cardiac output is the amount of blood pumped by the heart per minute, whereas total peripheral resistance refers to the overall resistance to blood flow in the small blood vessels. To reduce blood pressure, the treatment must reduce cardiac output by reducing the volume of blood or the rate and strength of heart pumping, and/or reduce peripheral resistance by reducing vasoconstriction in the blood vessels. We will be going through each of these drug classes which are used to treat hypertension. First, let's look at diuretics, which remove water from the body by increasing urination. To understand the action of diuretics, it is first necessary to review how the kidney filters fluid and forms urine. The kidney is made up of more than 1 million filtering units called nephrons. As blood flows into each nephron, it is filtered at the glomerulus. Here, water and other small molecules will enter the kidney tubules, while proteins and blood cells will stay inside the blood vessel. As the fluid moves along the tubule, most of the water is reabsorbed into the blood, along with the minerals and nutrients needed by the body. The remaining fluid and waste is excreted as urine. So diuretics work to increase urine production by acting on the kidneys. They work by reducing sodium reabsorption at different parts in the kidney, causing diuresis, which is water loss. This reduces the circulating volume, which reduces the cardiac output, and reduces the peripheral blood flow, which then reduces the peripheral resistance. There are 3 classes of diuretics: loop diuretics, thiazide diuretics, and potassium-sparing diuretics. Let's first look at loop diuretics. Loop diuretics work on the loop of Henle. If we look at the diagram, the loop of Henle is here. There is a thin descending limb, a thin ascending limb, and a thick ascending limb. In the thick ascending limb of the loop of Henle, there are sodium-potassium chloride co-transporters which pump sodium, potassium, and 2 chloride ions out of the tubule to be reabsorbed into the blood. The loop diuretics inhibit the sodium-potassium chloride co-transporter in the thick ascending limb of the loop of Henle. This causes sodium to stay in the tubules, trapping water in the tubules via osmosis. As a result, more water remains in the tubules, which moves to the collecting ducts and is excreted as urine. The sodium-potassium chloride co-transporter normally reabsorbs about 25% of the sodium load in the tubules back into the blood. Therefore, it is very effective to target this transporter, and loop diuretics are very effective diuretics. Loop diuretics also induce renal synthesis of prostaglandins, which increases renal blood flow, and this contributes to its efficacy. Examples of loop diuretics are furosemide, brand name Lasix, and bumetanide, brand name Burinex. Now let's look at thiazide diuretics. Thiazide diuretics inhibit the sodium chloride transporter in the distal tubule. So looking at the diagram, this is the distal tubule, and the sodium chloride transporter pumps sodium and chloride ions out of the tubules to be reabsorbed into the blood. So by inhibiting this transporter, more sodium would stay in the tubules, trapping more water with it, which is excreted as urine. Because this transporter normally only reabsorbs about 5% of filtered sodium, thiazide diuretics are less effective than loop diuretics in reducing sodium reabsorption and producing diuresis. However, thiazide diuretics are useful first-line agents in the treatment of hypertension because they have been proven to reduce long-term cardiovascular mortality and morbidity. In comparison, there is no outcome data for loop diuretics in the treatment of hypertension. Examples of thiazide diuretics are hydrochlorothiazide, And you can see HCTZ. That is not a brand name, but it is a common abbreviation for hydrochlorothiazide. And indapamide, brand name Natrelix. Let's look at the side effects of loop and thiazide diuretics. The most important and frequent problem with thiazide and loop diuretics is hypokalemia, which is low potassium in the blood. This sometimes requires treatment with potassium supplements, usually potassium chloride. It can also cause dehydration, leading to hypotension, which can cause dizziness. It can cause electrolyte imbalances, such as hyponatremia and hypomagnesemia, which is low sodium and low magnesium in the blood. It can cause hyperuricemia, which is high levels of uric acid, which can then induce flare-ups of gout. And for loop diuretics, they can cause hearing loss. There are also several drugs that interact with diuretics. NSAIDs can reduce the effect of diuretics because they inhibit the synthesis of renal prostaglandins. Corticosteroids can enhance hypokalemia when they are taken together with diuretics. Hypokalemia, which is a side effect of diuretics, can potentiate digoxin toxicity. Digoxin is a drug used in heart failure which has a narrow therapeutic index. Aminoglycosides are a class of antibiotics which can also cause ototoxicity, which is hearing loss, and nephrotoxicity, which is the kidney toxicity. So taking them together with diuretics can increase the risk of these side effects. Another class of diuretics are the potassium-sparing diuretics. They work by inhibiting the actions of aldosterone. Aldosterone is a mineralocorticoid hormone secreted by the adrenal glands, which increases the reabsorption of sodium from the kidney tubules into the blood by increasing the activity of the sodium-potassium ATPase pump in the kidney tubules. So when the action of aldosterone is inhibited, more sodium and water would be retained in the kidney tubules and pass into the collecting duct to be excreted in the urine. These diuretics are called potassium-sparing diuretics because they do not produce hypokalemia, unlike the loop and thiazide diuretics. They are seldom used alone. Instead, these drugs are often used together with loop and thiazide diuretics to prevent hypokalemia. Potassium-sparing diuretics reduce the excretion of potassium, which can then lead to hyperkalemia. They also reduce the excretion of H+ protons, which can lead to metabolic acidosis where the blood becomes too acidic. They can also cause gynecomastia, which is breast enlargement in men, as well as gastric problems, including peptic ulcer. Since potassium-sparing diuretics and ACE inhibitors both cause hyperkalemia, they should not be given together as the risk of hyperkalemia would be increased. As previously mentioned, NSAIDs may reduce the efficacy of diuretics. Now let's look at beta blockers. Before we look at the mechanism of action, let's do a quick recap. The sympathetic nervous system is responsible for the body's fight or flight response. It releases epinephrine and norepinephrine, which bind to alpha and beta receptors to bring about their effects. For this drug, beta blockers, we are interested in the beta-1 adrenal receptors, which are found in the heart. Activation of the beta-1 receptors results in increased heart rate and increased contractility of the heart. These are different from the beta-2 receptors, which are found in the lungs and cause bronchodilation. So beta blockers block beta receptors in the heart, which causes a decrease in heart rate and contractility of the heart. The older beta blockers are non-selective, meaning that they block both beta-1 and beta-2 receptors. Remember, beta-1 receptors are found in the heart and beta-2 receptors are found in the lungs. The newer beta blockers are more cardioselective in that they are relatively selective for beta-1 receptors. Cardioselective drugs have the advantage of lesser side effects since they do not block the beta-2 receptors in the lungs, which would then result in bronchoconstriction. Some examples of beta blockers are propranolol, labetalol, atenolol, and carvedilol. Beta blockers can cause a number of side effects. They can cause dizziness or lightheadedness, as well as fatigue. And this could be due to slow heart rate resulting in low blood pressure. Beta blockers can also cause cold hands and feet, which could be caused by affecting the blood supply to your hands and feet, as well as problems with sexual performance and ability, which is also linked to decreased blood supply. Beta blockers may cause insomnia, sleep changes, and nightmares. And some of the beta blockers, which are not cardioselective, can cause trouble breathing due to bronchospasm, and asthma patients would have a higher risk of having this side effect. Rarely, sometimes beta blockers may also cause depression. So since beta blockers can trigger bronchospasm, they should be used in caution in patients with asthma or COPD. And since beta blockers also decrease the heart rate, they must be used in caution in patients who have heart block or slow pulse, which is also known as bradycardia.